Hi everyone, my name is Liang Chen. I am a medical student from Tsuchi University and the creator of this video. I would like to sincerely thank Henry L. Lu MD, PhD, and Po Wei Chen MD for their guidance and support. The topic of this video is cervical spine anatomy and clinical exam. Let's take a closer look at the anatomy of the cervical spine and how to perform a proper clinical examination. The cervical spine, consisting of 7 vertebrae, connects the skull to the thoracic spine. Structures such as the facet joints, also called zygapophyseal joints, as well as the uncovertebral joints and the intervertebral discs ensure both mobility and stability. In the C2 to C6 vertebrae, facet joints are oriented at approximately 45 degrees to the horizontal plane, facilitating movements like flexion, extension, rotation, and lateral bending. C7, often called the vertebra prominens. It earns this name due to its long and prominent spinous process, which is usually easy to feel or palpate at the base of the neck. Because it's so easily palpable, C7 serves as a very useful landmark during physical examinations. We also have the spinal cord, which passes down from the brain, exiting the skull through a large opening called the foramen magnum and running within the spinal canal formed by the vertebrae. Although there are only 7 cervical vertebrae, there are 8 pairs of cervical nerve roots. The C1 nerve root exits above the C1 vertebra, and each subsequent nerve exits above its corresponding vertebra until C8, which exits below the C7 vertebra and above T1. In the thoracic and lumbar regions, the T1 nerve root exits below the T1 vertebra, and the L1 nerve root exits below the L1 vertebra. To systematically understand various neck conditions, we can classify them into 5 major categories based on the anatomic structure that's affected. First, muscle problems. These include issues like muscle strains or tears. Second, ligament problems. These include sprains, tears, or calcification of the ligaments. Third, arthropathy. Conditions like cervical spondylosis or facet arthropathy. Fourth, radiculopathy. This occurs when a nerve root is compressed, for example by a herniated disc. Patients often present with arm pain, numbness, or signs of lower motor neuron involvement. These include muscle weakness, decreased reflexes, and sometimes muscle atrophy. And finally, myelopathy. This results from spinal cord compression and is commonly seen in conditions like cervical stenosis. Myelopathy can lead to upper motor neuron signs below the level of compression, such as spasticity, hyperreflexia, clonus, and the positive Babinski and Hoffman signs. Let's take an example of what happens in a C4-C5 level myelopathy. Above the C5 level, neurological function remains normal. At the C5 level, we begin to observe lower motor neuron signs due to the involvement of the anterior horn at this spinal segment. This region contains the motor neurons that innervate the muscles supplied by the C5 nerve root. Clinically, this manifests as weakness in shoulder abduction, external rotation, and elbow flexion. Importantly, there is no spasticity. Instead, the biceps reflex may be diminished or even absent. Now, below C5, the descending tracts, especially the corticospinal tract, are affected. Since these are upper motor neuron fibers, we begin to see upper motor neuron signs. So, you'll start noticing spasticity, hyperreflexia, and clonus. The triceps reflex might be exaggerated, and you might even find clonus at the patella and ankle. Let's begin physical examination by assessing the patient's posture. Start by looking at head alignment and the cervical lordosis. Next, observe for muscle asymmetry or any wasting. Also, watch out for signs of torticollis. In this condition, the neck typically tilts away from the affected side. Surface anatomy can really guide us toward a more accurate diagnosis. Let's go through some important structures in the neck area. First, the trachea runs vertically in the midline, just beneath the skin and the strap muscles. To locate it, start by finding the thyroid cartilage, that's the Adam's apple, and then gently palpate downward. The trachea should be centrally located. Any deviation might suggest a mass effect, like from a goiter, a pneumothorax, or even mediastinal pathology. Next, the thyroid gland. The thyroid sits low in the front of the neck, spanning the second to fourth tracheal rings. It's usually not visible unless it's enlarged. In cases of thyroid goiter, the gland may appear visibly enlarged, especially when the patient swallows. Ask the patient to swallow water and observe. If a midline neck mass moves upward, that's characteristic of a thyroid lesion. Now let's move to the sternocleidomastoid, or SCM. This is a prominent muscle innervated by the accessory nerve. It runs obliquely from the mastoid process down to the sternum and clavicle. When it contracts, it turns the head to the opposite side and helps flex the neck. Lastly, the trapezius muscle. It's also innervated by the accessory nerve. It forms the posterior boundary of the neck and stretches from the occipital bone and the cervical spine all the way to the shoulder. Trapezius is important for scapular movement, and muscle wasting here can be a sign of accessory nerve injury. Now, palpate the cervical spine, starting from the base of the skull and working your way down to T1. As you do this, check for any tenderness or asymmetry. Let's walk through the palpation technique step by step. Step 1. Locate C7. Begin at the base of the neck and move upward. The first prominent spinous process you feel is usually C7, but keep in mind sometimes C7 and T1 can feel equally prominent. To tell them apart, ask the patient to rotate and flex their neck. C7 typically moves more during these motions, while T1 is more fixed, as it transitions into the stiffer thoracic spine. Step 2. Supraspinous and interspinous ligament palpation. With the patient's neck slightly flexed, gently palpate between each pair of spinous processes along the midline. These are the supraspinous and interspinous ligaments. Tenderness here could point to ligamentous strain, especially after whiplash or other flexion-extension injuries. Step 3. Facet joint palpation. The facet joints lie within the articular pillars, which are bony ridges formed by the alignment of the superior and inferior articular processes of the cervical vertebrae. To find them, move your fingers about 2.5 centimeters lateral to the midline and palpate along the articular pillar. Facet joint pain often presents as referred pain, so during palpation, assess whether the elicited pain resembles the patient's usual pain in quality and location. If you feel focal tenderness here, it may suggest a painful facet joint as the underlying source. To accurately assess the cervical spine's range of motion, we can use a goniometer to measure the angles precisely. Let's go through each movement and see how it's done. First, let's start with flexion. Center fulcrum of the goniometer over the external auditory meatus, aligning one arm perpendicular to the floor and the other with the base of the nose. Then, ask the patient to bring their chin toward their chest. In a normal range of motion, the patient should be able to achieve about 50 to 60 degrees of flexion, with the chin touching the sternum. Now, moving on to extension. Keep the goniometer in the same position, and instruct the patient to tilt their head back. Ideally, they should reach around 60 to 70 degrees, where the face becomes nearly parallel to the ceiling. Next, let's check axial rotation. To measure this, center fulcrum of the goniometer over the center of the head, aligning one arm with the tip of the nose and the other parallel to an imaginary line between the left and right acromial processes. Ask the patient to turn their head to the left and then to the right. A normal range of motion is about 70 to 80 degrees in each direction. It's important to ensure symmetry when comparing both sides. Finally, let's assess lateral bending. Center fulcrum of the goniometer over the C7 spinous process, with one arm following the thoracic spine and the other aligning with the dorsal midline of the head, using the occipital protuberance for reference. Ask the patient to bring their ear towards their shoulder, without shrugging. Normal lateral bending should be around 40 to 50 degrees on each side. Limitation of range of motion is a non-specific finding that suggests a problem with structures around or within the joint. If pain occurs during testing, we should consider which underlying structure is being pinched or stretched during the movement. Using a goniometer ensures precise measurements and helps track progress over time. However, if the patient has cervical spine instability or experiences severe pain during movement, this assessment should be avoided. To help differentiate muscle strain from other causes of neck pain, we can perform resisted isometric tests. These tests activate specific contractile structures, mainly muscles and tendons, without allowing movement. This helps isolate pain that originates from these tissues. Here's how to perform the test. Ask the patient to resist your hand as they attempt to move their neck in different directions, but make sure no actual movement occurs. You're testing the neck flexors, extensors, lateral flexors, and rotators one at a time. For neck flexion, place your hand on the patient's forehead and ask them to push forward without moving. For extension, place your hand on the back of the head and have them push backward. For head rotation, place your hand on the side of their head and resist as they turn it left and right. For lateral flexion, place one hand on the side of the head and resist as they try to bend toward that side. Pain during isometric contraction without neurological signs often suggests muscle lesions. When assessing cervical nerve root function, each nerve root corresponds to a specific sensory area on the body. Starting from the top, the key sensory point of C2 is located at least 1 cm lateral to the occipital protuberance, or 3 cm behind the ear. C3 corresponds to the supraclavicular fossa at the midclavicular line, and C4 is over the acromioclavicular joint. C5 is on the lateral side of the antecubital fossa, just above the elbow. C6, C7, and C8 correspond to the dorsal surface of the proximal phalanges of the thumb, middle finger, and little finger respectively. T1 is located on the medial side of the antecubital fossa, just proximal to the medial epicondyle of the humerus. To evaluate sensory function, light touch and pinprick testing should be performed at each of these key points. The patient's face can serve as a reference for normal sensation, which ought to be normal in any spinal lesion. In the pinprick test, if we assess only for the presence of pain sensation, we may miss cases of allodynia, where patients perceive any sensory input as painful. Therefore, we should first ask them to differentiate between pain and a dull sensation, and then compare the intensity of the pain that was felt on the face. These tests identify sensory abnormalities that may suggest radiculopathy, myelopathy, or peripheral neuropathy. In addition to key sensory points for each nerve root, specific key muscles that correspond to specific nerve roots should also be tested. C5 controls elbow flexors. Test this by asking the patient to resist your pull and attempts to maintain the elbow flexed at 90 degrees, assessing the biceps and brachialis. C6 is for wrist extension. Have the patient extend their wrists against resistance, checking the extensor carpi radialis. C7 controls elbow extension. Ask them to push their arm out straight against your hand, assessing the triceps. C8 is for long finger flexion. Ask the patient to hold the tip of your finger in the bent position of middle finger, testing flexor digitorum profundus. T1 controls small finger abduction. Test this by asking the patient to hold little finger away from ring finger, evaluating the abductor digiti minimi. Check each side for strength and symmetry, then assign a score from 0 to 5 for each movement to document the muscle power accurately. 0 means no muscle activity. 1 means a visible or palpable muscle contraction. 2 means full range of motion, with gravity eliminated. 3 means full range of motion against gravity. 4 means against moderate resistance. 5 means against full resistance. Next, let's perform reflex testing, which helps us localize possible neurological lesions. Start with the upper limb reflexes. The biceps reflex tests C5. The brachioradialis reflex corresponds to C6. The triceps reflex is associated with C7. Now for the lower limbs, the patellar reflex tests L3, and the ankle jerk reflex checks S1. Hyperreflexia, meaning overactive or exaggerated reflexes, is an upper motor neuron sign, which may suggest myelopathy. On the other hand, hyperreflexia, or reduced reflexes, is a lower motor neuron sign, which may suggest radiculopathy or peripheral neuropathy. Always compare both sides and make notes of any asymmetry. That's often a key clinical clue. Now, let's explore 2 tests for assessing cervical pathology. First, the Hoffman sign. To perform Hoffman sign, flick the patient's middle fingernail downward and watch their hand closely. A positive Hoffman sign is when you see involuntary flexion of the thumb and index finger. This indicates an upper motor neuron sign, often seen in conditions like cervical myelopathy or stroke. Hoffman's sign has a sensitivity of 59% and a specificity of 49% for detecting cervical cord compression. Next, the Sperling test, also known as the compression test, which assesses for cervical radiculopathy. Start by asking the patient to gently extend their neck and bend it toward the symptomatic side. Take a moment to observe the movement first. Sometimes, this alone can already provoke symptoms. If there's no immediate reaction, you can then apply gentle downward pressure on the top of the patient's head. A positive Sperling's test reproduces radiating pain along a nerve root pattern, such as shooting pain down the arm, by narrowing the space around the cervical nerve roots, indicating nerve root compression or irritation. Always observe the patient's response before applying pressure, as this test can potentially worsen symptoms if they're already present. The Sperling test has a sensitivity of 59% and a specificity of 84% for detecting cervical radiculopathy. Besides physical examination, be alert for red flags suggesting serious conditions like myelopathy, spinal epidural abscess, or spinal tumor. These red flags can include fever, weakness, unexplained weight loss, a history of cancer, high energy trauma, such as a major fall or car accident, bowel or bladder dysfunction, which may suggest spinal cord involvement. If any of these red flags are present, further investigation or referral is necessary. Which cervical nerve root corresponds to sensory innervation of the thumb? A. C5, B. C6, C. C7, D. C8. The answer is B. C6. Here's my mnemonic for the sensory points of C5 through T1. Red thumbs make little unicorns. C5, red. This refers to the radial side of the antecubital fossa. C6, thumbs. This corresponds to the thumb, specifically the dorsal surface of the proximal phalanx. C7, make. This represents the middle finger, also the dorsal surface of the proximal phalanx. C8, little. This indicates the little finger, again, the dorsal surface of the proximal phalanx. T1, unicorns. This points to the ulnar side of the antecubital fossa. If the patient cannot resist moderate resistance, what is the next appropriate positioning for further assessment? For grade 3 assessment, the patient lies supine with the shoulder in neutral rotation and 90 degrees flexion, the elbow totally flexed, and the palm resting by the ear to allow elbow extension against gravity. For further grade 2 assessment, support the arm to position the triceps in a horizontal plane and minimize gravity resistance. Which of the following are considered red flag signs that may suggest a serious cervical spine condition? Select all that apply. A. Fever. B. Unexplained weight loss. C. Gradual onset of neck stiffness without trauma. D. Bowel or bladder dysfunction. E. History of cancer. The answer is A, B, D, and E. You are correct.